So my name's Georgia. I've just done my 2 years as a GP registrar and I've finally finished and I've enjoyed every single week. I have not looked back. It's been awesome. When I started, beginning of 2017, I got this thing back called a life that I hadn't had for 2 years prior to that, and it was awesome. I got to have lunch, I got to go home and cook dinner, and I got to do stuff on the weekend. I didn't have to apply for leave and then get rejected like 3 months later. So everyone knows that GP, you do have a life. If you have a life, you love your job better. I mean, is that what the law of attraction is? I think that's what it is. It's really good. It's good. We all know that doctors need to look after ourselves because we're really bad at doing that. This is me looking really happy, hopefully not too forced. This is me in Margaret River on one of the weekends that I decided to go down. The other thing that kind of hits you when you are a registrar and you get it really early on is that you do get a lot of autonomy. You do have a lot of you know, the first day that you're a GP registrar, it's just you and a patient and that's it. And there's no team to hand over the next day, there's no senior doctor coming in and saying, why did you do that? Your decision is the bottom line, and it's such an amazing thing. It really makes you question every decision you make. You really are thinking, oh, is this evidence-based? I actually better do this and not just like ignore stuff. Like, you know, you're not like a super secretary like an intern is. There's a lot of paperwork, but there's also a lot of decision work, which is just awesome. This is what we train for, right? And it's not all coughs and colds. There is a lot of that. And sometimes you love that because then you can catch up when you're behind. But every specialty has their coughs and colds, their bread and butter, but you're never going to get this anywhere else in any other specialty. If you want to see real medicine and such a breadth, I literally saw all these in my first 6 months. I don't even think I knew what half of them were. And anyone notice my subliminal messaging there? I made these cases last year and I'm struggling to remember them, but I'm just going to talk about them and try to remember them. So one thing is that you don't have blood tests straight away. You don't have a CT scans or MRIs. You have to actually realise that you're going to be really thinking about what you're doing seriously because you just don't have answers like that. And it really, really makes you question yourself. It makes you a better doctor. I'm sorry, I really can't remember this case. I'm just going to move on. I do remember this case though. This was a lady, she was like one of those posh, like elderly ladies who was going to the Swan Valley for lunch, and she said, I woke up this morning and I've been breathless ever since. And I was like, probably not worrying, except for the fact that she had an MI in 2010, and I was like, uh-oh, I don't think she should go. And I realised I have to talk this lady into going to the emergency department on a Friday morning when she was going to go to have lunch, and I don't even think anything's wrong with her, and she's going to hate me. She's really going to hate me. She ended up having a stent 2 hours later, and she wrote me a handwritten letter and said, if you hadn't have explained that to me, I would not have gone to the emergency department and I could be very, very sick right now. Maybe not even here. Probably not. But anyway, point is, you guys are all picked for being communicators. You all got into med school. I'm assuming there's no non-medical people here. And if there are people that every single person in Australia is just like, I just want a doctor who can explain things to me. I want to understand what's going on. If you can do that, you will be so valued as a GP that you will just love your job so much. Honestly, you guys are all millennials/Gen Z. I know how much you think you're undervalued in life. If you want to feel valued and you're good at communicating and you have a passion to help people, empower them with the knowledge that they can make the best decisions for their health, they will love you forever. And they don't always show it in a nice way, but the ones that do, it's totally worth it. So yeah, if you're a good communicator, you should definitely think about general practice. This was a young teenage girl, had just an awful life. Nothing went right for her. She had no parents, nothing stable in her life. Not even her caseworker was stable, so she was foster child DCP kind of case. And I remember she came in when I was in like my 3rd or 4th month of being a GP, and she was just like, that's it, I'm going to go to Beaufort Street and lie down and try to kill myself. And I was just like, I have no idea what to do with this girl. And I just decided, I'm just going to be here. I'm going to say, all right, cool. that's what you're going to be like. I'm just going to let you be you, and you know what, come back in 2 weeks and let's just figure it out. And she came back every 2 weeks for months, and eventually she became a different person. It's not until you see that sort of change in a person that you can actually understand what it's like to treat someone as a general practitioner. And I didn't understand it before I started. I was like, oh yeah, sure, it must be cool to see someone born and then have their children, but it's not, well, then have their own children, but it's actually the most rewarding experience that I've had as a registrar, and I can talk about it all day, but it's something that you're really not going to get as much in a lot of other specialties, seeing all this continuity from A to Z. Now, a good general practitioner who can actually treat the whole person and tie all the strings together into a neat little package and decide what is best for this person that they want is worth more than if we got every single specialist in a room to try to figure out what to do with that patient. And that's because we are treating the whole person and not just coming at it from one point of view. If you think you are going to be good at that, you will be a great GP. Aristotle knew this. He was a very wise man. He knew that general practitioners are the most effective doctors. We live in a world of preventative health. Chronic disease, sorry. There's a bit of acute medicine, but it's mainly chronic disease. And if GPs, we are the masters of preventative health, and so therefore if you want to make a difference, the most effective way you can do that is through community medicine and being there in front of patients every single day, telling them, teaching them what to do. I said this last time, in Sweden, the top school graduates get to be high school teachers because they teach the next generation. We should have our top doctors becoming general practitioners because we are the ones educating people about what to do in their life. And unfortunately, I think that everyone has the idea that it's the other way around. You do GP if you can't do anything else, and it's just a terrible thing. And I think if we switch that, we have the ability to make such a big difference in health in Australia. And I'm not trying to guilt you into being a GP, but if you are a good doctor, you should feel guilty if you don't do general practice because you have such an ability to make a difference to someone. So I think have a serious think about it. I think the pathway on the right is general practice because it's kind of a bit varied and different, and that's it. You can do a lot of stuff as a GP. You can choose to make it about obstetrics or surgery. You can choose to make it about rural or living in the city or working part-time, which is may or may not be what I'm doing at the moment. So, yeah, I think that's all I've got to say. I think we can go on to questions.
Are you able to come back and do the FAR GP part of that bit later on, or is there a time requirement on it? Or?
No, you can. If you've done got your fellowship, FRACGP, and you did rural exposure as a part of that, so you did community medicine as a part of that, and then you decided later as an independent practitioner you want to sign up and do your FAR GP, you can do that directly with the RACGP. So you can do it as a registrar, or you can actually choose to gain that additional fellowship later. So that's fine. Yep.
Similar sort of principles apply for the advanced, like the specialities part at the end. Can you come back and say, you know, I've done X, Y, Z years in community general practice. I'd like to be a GP surgeon now. Can you come back and add that on, or is it a bit more complex than that?
Okay, so GP surgery is quite complex. You wouldn't. Look, I'll be honest, once you become an independent practitioner, not very many of them return to the hospital system, okay? Because we become very, very autonomous and we don't cope very well with being told what to do by other people. So it's true, you become very autonomous as a GP. So if you really want to be a GP surgeon and you've become a fellow practitioner, yes, you could do it. It's like becoming a GP anaesthetist after you've become a GP and you've practiced for a while. And there are some rural general practitioners who come back and do GP anaesthetic training and gain that qualification later after they've been working as a rural GP for a period of time. But it's easier to streamline your training and do it as a registrar. Yep.
How many applications does the colleges receive per year?
So,
and how many get in?
Okay, so there are 1,500 places across the country. In WA, we get about 180 to 190 each year. I don't think the number for next year has been confirmed, of which there's approximately 70 rural pathway and the rest are general pathway. Okay, out of the total number for Western Australia, we also get, well, for 2019, I've got to think this is this year now, 2019, 30 of the places were identified as being rural generalists. So all of our 15 ACRM trainees were considered rural generalists because they have to do that advanced specialised training year. And of our RACGP, the rest were RACGP cohort. And at the moment we've identified about 15 from the new cohort who are going to sign up and do the FAR GP. So that fills the rural generalist training positions, but they are a part of our 180 that we were allocated for WA for WAGPET this year. I know it's a little bit confusing. Yep.
180 spots.
Each year.
How many applications?
Oh, so how many applications? Okay. Right, well, each college has got different numbers. So for our 15 ACRM positions, we interviewed about 21 to 22 people. Okay, there were some who were not suitable for a variety of reasons, and there were some people who chose not to take a spot, but we ended up filling all of our ACRM. And don't quote me on these numbers, I'm giving you a broad idea. For our RACGP numbers, we ended up having 3 rounds of interviews to fill them all, and we only ended up being 3 short. So out of our we had 187, we filled 184 places, including all of our ACRM. And we had to interview 3 times. So the government reopened interviews throughout the year, so people with their permanent residency became eligible to then apply. We were down on application numbers in 2018 and 2017, and we're not really quite sure why, but we think the 3-year contract in Western Australia had an effect, because with the AMA you'd all signed up to a 3-year contract and you were not really thinking about leaving the hospital-based system until you'd finished that. There were quite a few different things. We now have postgraduate medical schools in Western Australia. Curtin's coming on board, which is great because that's undergrad as well, but you're all a little bit older, you're looking at having kids and moving on, and so that affects when you want to go into GP as well. All these things come into the mix when we look at why there are less or more applications. So, but at the moment it's still 1,500 places each year, and we normally get, Sydney's very, very busy. Like everybody wants Sydney over in the eastern coast, and WA we've generally been able to fill all of our places with each year. Yeah. Yep.
If you train with ACRM, are you limited to working only rural?
No. You get an internationally recognised fellowship in general practice. It's not as broadly recognised yet as the RACGP, but the college is working on that. Yeah, it's newer, that's all. It's just got to get out there. Yeah. Yep.
There's an article at the moment that there's a sort of a magazine like the Australian Doctor, and it thinks that the reason why those places, GP placements, weren't filled is the fact that the billing, like the MBS, hasn't sort of gone up, increased with consumer price index year on year.
That's a real stretch. Okay. Yeah, we're getting into politics. So each region, each state is different. As I said, so Sydney, which is run by GP Synergy, I don't even know their numbers off the top of the head of how many people they take each year. But Sydney and New South Wales and Queensland, they have a much larger population than WA, and they are often oversubscribed. However, if you talk about Northern Queensland and Northern Territory, sometimes they're undersubscribed because less doctors want to go there. So it really varies across the state. I think it's multifactorial as to why the application numbers have dropped off. Things are changing with, surgical training and basic physicians training, and we've had, how many people are going into ED training? We've got lots of FACEMs, and so there's a natural wax and wane, but I can't really comment on whether it's got to do with the freeze on the Medicare billings or not. So, So that's, yeah.
I don't think it's got anything to do with the freeze on Medicare billing, because I don't think most people would be aware of that. But it's unfreezed now, 10 years later. The other thing is, when I applied, and I don't think it might be slightly different, but to get into Melbourne or Sydney, you had to be in the top 10 or 20% of ranking on the scores to get into AGPT. But for WA, it was, I think everyone that applied that was suitable.
Everybody that was suitable was offered a place.
Was offered a place,
not
so it's
everybody
different.
is found suitable after the selection process. Yep. And we've probably got time for one more, and then I think we'll need to stop so the next group can come in. Yep.
Going back to salaries, how does the salary of a GP trainee working in their first, second term in general practice compare to the previous salary in hospital?
Okay. It depends on where you're working. It does depend on whether you're in a bulk billing or a private practice billing, but there is a document called the National Terms and Conditions for the Employment of Registrars. When you go into the community practice setting, you are employees of the practice, and there is a minimum wage that you must be paid by the practice. The more patients you see and the more you bill and the better you get at using the appropriate Medicare item numbers for the work that you're doing, the more your income goes up. So yes, there is a drop, but you're also not doing on-call. If you were just doing community practice without on-call, so I'll park my rural generalists who are working in a hospital to the side at the moment, but if you're just doing community general practice and you are not doing Saturdays, say, or not doing evenings where you do get private billings, your income will drop. So, but the document is available on the website and it's reflective of the AMA rates. The AMA is a part of that negotiation, and there are minimums that you will get paid, and then you usually get paid above it.
I'd also add to that as a GP1 registrar, when that base rate does drop, and by the way, a lot of GP1 registrars earn more than that depending on private billings and that sort of stuff, you are only working, I think, 31 to 33 hours a week, so there's also that difference because you've got teaching and things like that. And then it goes up quite dramatically, but I think after about 6 to 12 months, I think most GP registrars are earning based on billings, so, and then that just depends on how many patients you're seeing, how many hours, and private or bulk billing.
Okay, and I'm going to leave it there, but we do have the GP stakeholder booth, so please come and ask questions. And if you sign up to our expression of interest form, you'll get a box. Okay.